My name is Jake Spitzer. I chose to do my case study for pathophysiology on osteoporosis. Osteoporosis is a condition characterized by weak, brittle, and porous bones that are more susceptible to fractures. To fully understand osteoporosis, basic bone physiology is necessary. Bone composition is made up of a matrix of collagen fibers, calcium, and phosphate. This provides strength and structure for bones. Throughout life, bones undergo a continuous process called remodeling, which involves the removal of old bone tissue by cells called osteoclasts and the formation of new bone tissue by cells called osteoblasts. This helps the body maintain bone strength and repair any micro damage that may have been done to bones. Additionally, bone density and strength refers to the amount of mineral content per unit volume of bone. Higher bone density usually refers to stronger bones. Peak bone mass is typically achieved in early adulthood and is influenced by genetics, diet, activity, and hormonal balance. For the pathophysiology of osteoporosis, there are three main points, those being increased bone resorption, decreased bone formation, and disruption of bone microarchitecture. For the first point, and tied into the second point, in osteoporosis, there's an imbalance between bone resorption and formation, with the increased activity of osteoclasts leading to increased breakdown of bone tissue, resulting in a net loss of bone mass and density. While the bone is being resorbed at an increased rate, it is also being formed at a decreased rate. In osteoporosis, there is a decrease in bone formation by osteoblasts. This could be caused due to factors such as aging, hormonal changes, vitamin D deficiency, and medications. Lastly, there's a disruption of bone microarchitecture in osteoporosis. Normally, the bone structure is spongy, but with osteoporosis, it becomes thin and porous, reducing bone strength and increasing the risk of fractures in weight-bearing bones such as the spine, hips, and wrists. Contributing factors for osteoporosis include age. Bone density tends to decrease with age. Gender, women are more prone to osteoporosis, especially after menopause, due to estrogen decline. Next would be hormonal imbalance. Low levels of estrogen or testosterone can accelerate bone loss. Additionally, nutritional deficiencies can contribute to osteoporosis. With an inadequate intake of calcium and vitamin D, this can lead to weakened bones. Next, lifestyle factors, a lack of physical activity, smoking cigarettes, excessive alcohol consumption, or a diet poor in nutrients can increase the risk of osteoporosis. And finally, genetics. Family history of osteoporosis or fractures can predispose individuals to osteoporosis. Osteoporosis is often termed a silent disease because in the early stages of osteoporosis, people are typically asymptomatic and without any symptoms until a fracture occurs. Many people are unaware that they have osteoporosis until this fracture occurs or if they undergo bone density testing. Some of the common fractures in osteoporosis include the weight-bearing bones such as the vertebrae, hips, humerus, pelvis, and additionally the wrists and the ribs. Other signs and symptoms can include height loss and postural changes. As vertebral compression fractures occur, This can lead to a gradual loss of height over time. Additionally, osteoporosis can lead to curvatures of the spine, such as kyphosis, leading to a abnormal posture, and these posture changes can affect the patient's mobility, balance, overall quality of life. Typically, once a patient is symptomatic, there can be chronic pain associated with the fractures and the aftermath of the fractures. Additionally, there can be functional impairment due to the fractures and any pain associated with the fractures. This can impair the patient's mobility, limit their activities of daily living. They may have difficulty walking, climbing stairs, or performing tasks that they used to be able to do independently. Some of these changes in their life can have a psychosocial impact, fear of going outside and doing activities that may lead to falls or sustaining additional fractures, the limitations from the pain. This can lead to depression, anxiety, social isolation, and a decreased quality of life. Additionally, there can be complications caused by the fractures and osteoporosis. Having these fractures and osteoporosis can make individuals at a predisposed risk to DVTs, pulmonary embolisms, pressure ulcers from lack of mobility, and pneumonia, again, due to lack of mobility. There are several laboratory tests that may be completed to aid in the diagnosis of osteoporosis or the monitoring of the disease. This may include serum calcium and phosphorus levels. Abnormalities in these levels may indicate underlying metabolic bone disorder that is contributing to osteoporosis. Additionally, vitamin D levels may be monitored. Vitamin D is associated with decreased calcium absorption and impaired bone mineralization, therefore again affecting osteoporosis. And additionally, bone turnover markers may be monitored. These are biomarkers of bone resorption and bone formation, and this gives the provider insight into how the bones are remodeling, and if resorption is elevated or formation is elevated, this may help in the diagnosis. Additionally, parathyroid hormone and thyroid hormone function tests may be monitored. Elevated levels of parathyroid hormone may indicate secondary causes of osteoporosis, such as hyperparathyroidism, and thyroid disorders can also affect bone metabolism and contribute to osteoporosis. Several radiological diagnostic tests may be used to monitor osteoporosis or diagnose it. This includes bone mineral density testing. This is an X-ray absorptiometry test, also known as a DXA or DEXA scan. These scans measure bone density at specific sites, specifically the hip, spine, or forearm. Results are then reported as T-scores, which compares the patient scan to that of a healthy young adult, and a Z-score, which compares their scan to an age-matched peer. A T-score of -2.5 or lower indicates osteoporosis, while a T-score between -1 and -2.5 indicates osteopenia or low bone mass. Additionally, a vertebral fracture assessment may be completed. This is a specialized form of a DXA image that focuses specifically on the spine to identify any vertebral fractures. Next, regular X-rays may be used to identify bone density, structure, and looking for any fractures that may already be present. Quantitative computed tomography, or QCT, is a measure of bone density using CT scans. It provides 3D images that can be used to assess bone density at several sites, including the spine and hip. A variation of the QCT is the peripheral QCT. This focuses on sites that are peripheral in the body, such as the radius and the tibia. It again assesses bone density and structure in these regions. There are several medications that may be used to treat osteoporosis or slow its progression. These include biphosphonates, selective estrogen receptor modulators, calcitonin, teriparatide, denosumab, and hormone replacement therapy. Biphosphonates inhibit bone resorption by targeting osteoclasts. This slows down bone loss and therefore reduces fracture risk. Common examples of these types of medications are Fosamax, Actonel, Boniva, and Reclast. Some of the side effects of these medications include gastrointestinal issues such as nausea, abdominal pain, esophageal irritation. Rare side effects of biphosphonates may include atypical femur fractures, osteonecrosis of the jaw, and acute reactions with intravenous administration. Contraindications for biphosphonates include severe renal impairment, hypocalcemia, esophageal abnormalities, and the inability to sit upright for at least 30 minutes after taking the medication orally. Selective estrogen receptor modulators act as estrogen agonists and antagonists depending on the type of tissue that they are affecting. They help to preserve bone density by reducing bone resorption without increasing the risk of estrogen-related cancers, which can be a side effect of some other treatments. Common examples of this medication would be Evista. Side effects of these medications can include hot flashes, leg cramps, and peripheral edema. There can also be an increased risk of venous thromboembolism and a very rare side effect of strokes. Contraindications for selective estrogen receptor modulators include a history of venous thromboembolism, current or recent in the past year estrogen-dependent cancer, and severe hepatic impairment. Calcitonin is another medication that may be tried in osteoporosis. It can inhibit osteoclast activity, thereby reducing bone resorption and decreasing fracture risks. It's particularly useful in vertebral fractures. The common example of this medication is salmon calcitonin. Side effects of calcitonin can include nasal irritation if taken in the form of a nasal spray, flushing, nausea, injection site reaction if injected. Long-term use of calcitonin can lead to tachyphylaxis and allergic reactions. Contraindications for calcitonin include hypersensitivity to calcitonin or salmon-derived products, Paget's disease of the bone, and severe renal impairment. Teriparatide may also be used with osteoporosis. It is also known as recombinant parathyroid hormone 1-34. This hormone stimulates bone formation by activating osteoblasts, which can lead to increased bone density and improved bone strength. The common example medication for this medication is Forteo. Some side effects of the medication can include nausea, dizziness, headache, injection site reactions, and very rarely it can increase the risk of osteosarcoma. Contraindications include a history of skeletal malignancies, hypercalcemia, and conditions that may predispose the patient to hypercalcemia, such as hyperparathyroidism. Denosumab is another medication that can be used in osteoporosis. It is a monoclonal antibody that inhibits a protein involved in osteoclast activation. By reducing the osteoclast activation, The medication helps increase bone density and therefore reduce fracture risk. The common side effects of the medication include musculoskeletal pain, fatigue, dermatological reactions, and it may increase the risk of infections and other conditions of the skin. Contraindications of the medication include hypocalcemia and hypersensitivity to the medication or any components of the medication. Lastly, hormone replacement therapy, or HRT, may be used to treat osteoporosis. In HRT, it replaces estrogen and/or progesterone in postmenopausal women to help maintain bone density and reduce their fracture risk. The examples of this would be any of the various estrogen and progestin formulations that are available. Side effects of these medications can include breast tenderness, vaginal bleeding, mood changes. Long-term risk of hormone replacement therapy may increase the risk of breast cancer, cardiovascular events, and strokes. Contraindications for the use of hormone replacement therapy include estrogen-dependent cancers, active thromboembolic disorders, liver disease, and uncontrolled hypertension. Some coexisting disease processes that can be found in people with osteoporosis include type 2 diabetes, rheumatoid arthritis, chronic kidney disease, inflammatory bowel disease, and chronic obstructive pulmonary disease. Chronic hyperglycemia can promote the formation of advanced glycation end products, which accumulate in bone tissue and can impair bone quality. Additionally, low-grade inflammation is associated with type 2 diabetes, and this inflammation can disrupt bone remodeling and contribute to bone loss. Rheumatoid arthritis is an autoimmune disorder characterized by chronic inflammation. This can lead to joint destruction and systemic manifestations. Again, the inflammation caused by rheumatoid arthritis can stimulate osteoclast activity and suppress osteoblast activity, resulting in bone resorption and erosive bone changes. Chronic kidney disease is characterized by progressive loss of kidney function, leading to disturbances in mineral metabolism, electrolyte balance, and vitamin D metabolism. Reduced renal function can impair how phosphate is cleared through the kidneys and how vitamin D is converted to the active form. Due to this can affect the homeostasis of the bone development, thus leading to osteoporosis. Inflammatory bowel disease, including Crohn's disease and ulcerative colitis, again has chronic inflammation associated with it. The inflammation drives cytokine production, and this can contribute to, again, systemic inflammation and bone loss. Lastly, chronic obstructive pulmonary disease is characterized by airflow limitation, again, chronic inflammation, and structural changes in the airways and lungs. This systemic inflammation, along with oxidative stress and physical inactivity associated with COPD, can contribute to bone loss and muscle wasting. There can be several components to education for patients with osteoporosis. These would include understanding the disease, medication management, lifestyle modifications, fall prevention, modifications to activities of daily living, and regular follow-up and monitoring of osteoporosis. For the first point, understanding the disease, it can be important to explain pathophysiology of osteoporosis, informing them of bone resorption and bone formation imbalances and how this can lead to weakened bones. It's important to also discuss risk factors that were discussed earlier in the presentation, such as age, sex, family history, hormonal changes, nutritional factors, and lifestyle habits. And it is also important to stress the importance of bone density testing for diagnosis and the continuing monitoring of osteoporosis progression. Next would be medication management education. This would include the purpose of the medications, the benefits, the side effects, any administration instructions, when to contact the doctor if they are having certain reactions, and emphasizing the importance of the medication, adherence to the best treatment outcomes and reduced fracture risk. Next would be lifestyle modifications. Encourage any regular weight-bearing exercises such as walking or strength training. Balance exercises can also improve bone density, muscle strength, and balance. This helps reduce the risk of falls and fractures. It's also important to emphasize the importance of a balanced diet rich in calcium and vitamin D to support bone health. Provide guidance on calcium-rich foods such as dairy products and leafy greens, and sources of vitamin D such as sunlight exposure, fortified foods, or supplements. As smoking is also a risk for osteoporosis, it's important to discuss smoking cessation, and additionally also limiting alcohol intake, as both of these can impair bone health and increase fracture risk. Next would be to educate the patient on fall prevention strategies to reduce risks of fractures. This can include removing tripping hazards, improving lighting, using assistive devices such as handrails, grab bars, walkers, etc., and wearing appropriate footwear that will put them at the least risk for falls. Additionally, you can encourage regular vision and hearing assessments, as sensory impairment can lead to an increase in the risk of falls. It is also important to provide guidance on modifications to daily living, activities of daily living to minimize the risk of fractures, such as using proper body mechanics when lifting heavy objects, avoiding high impact activities that could increase the risk of falls, and again using assistive devices such as canes, walkers, grab bars, etc. Lastly, you want to emphasize that regular follow-up and monitoring is important. This allows your healthcare provider to assess your bone health, the efficiency and efficacy of the medication that is prescribed, and to monitor for any fracture risk or fractures that may have developed. It's important to encourage open communication with healthcare providers to address any concerns with treatment options, medications, etc., and so the patient can make informed decisions about managing their osteoporosis. In conclusion, osteoporosis is a often silent but serious condition characterized by weakened bones and increased fracture risks. It results from an imbalance between bone resorption and bone formation. This can be influenced by factors such as age, sex, hormonal changes, and lifestyle habits. Effective management of osteoporosis involves a multifaceted approach, including medication therapy, lifestyle modifications, fall prevention strategies, and regular monitoring. Through education and collaboration with healthcare providers, individuals with osteoporosis can take proactive steps to protect their bone health, reduce fracture risk, and maintain independence with a good quality of life. Thank you for listening to my presentation.